Good morning. You're muted there, Gilbert. Okay,
How are
go
you?
ahead. How are you today?
I'm fine, thank you. I'm fine, thank you. And you?
Very good. You're working, huh?
Yes, just relaxing now. I'm just sitting down now, just relaxing.
Oh, okay. Okay, yeah. Dr.
Just
Goel.
waiting for the session to start.
Yeah, he speaks in about 15 minutes.
Yeah.
Dr. Goel is speaking first.
Otherwise, how are you doing?
Well, just going to the beach.
Okay, I'm seeing you are in the beach.
Yeah, I'm going to the beach. No, the beach is
Okay.
empty now. The beach is empty now. It's
Okay. Nobody's there because of the coronavirus.
yeah, I think so. I think because they don't encourage you to go outside, you know. So
Okay.
I don't think anybody's at the beach. Maybe walking around, but not at the beach. I think all parks are closed. All parks, all public places, you know. Probably the
Yes.
same as you. You're in where are you? Kenya, right?
Yes, exactly, from Kenya.
Yeah, yeah. Are you in the main city, the capital?
Yeah, capital city, Nairobi.
Nairobi. Okay, it's a big city, right?
Yeah.
Very, very big. The capital, right?
Yes.
Khalif, is he at the hospital? The same hospital?
Okay.
Is Khalif there? Khalif at the same hospital? He's a neurosurgeon from Kenya.
Yes. Yeah. Even Dr. Musawa, neurosurgeon, Njiro.
Yeah. Okay. Okay.
Yes.
Very good. Okay, I'll be back. Okay.
Okay, fine.
Okay. I just you need to stay. You know where the mute button is? The mute button, because you have to stay mute when you're not talking here. Oh, there you are. Okay, I'm gonna put the mute on for you. Okay. Okay. Oh. Hitesh, please. Hello to Hitesh.
Yes, hello.
Yeah, hi. I'm gonna keep you muted, okay?
Okay, okay, I start video. Okay.
Okay, I mute you now, okay? Okay.
Hi, John.
Hey, good day.
How are you?
Good, Dr. Shah.
Yeah. He'll be there in another 5 minutes, I think.
Oh, are you at the same hospital?
Yes, I'm at the same hospital.
Oh, cool. Well, I didn't know that. Oh, because I saw you from another conference that had nothing to do with Dr. Goel.
Yeah, I'm from the same hospital.
Yeah,
I work.
okay. Good, good.
Yeah.
Yeah, you took part in the Japanese webinar for Dr. Kato.
Yes.
Okay, we'll be starting in a few minutes.
Yeah.
He likes this platform.
Yeah, he likes it.
Yeah, you can tell, right?
Yeah, you can tell.
Why does he got a good connection? Why does he got a good connection, man?
The problem is with the internet because too many users. That is the problem.
Yeah,
I guess.
I think everyone understands.
Yeah.
It's a common problem, so you don't really have to explain.
Yeah. Let's hope today is good.
Yep. Is there an Indian god of the internet?
Is it an Indian?
Is there a god of the internet?
No.
I should put him next to me here.
You have to pray for. You can put Ganesha there.
Yes, hey, if it works, we'll do it.
For all auspicious beginnings, I guess.
And then when it happens, I just get it out and rub his belly.
Yeah. Today we got Miami Beach in the background.
There you go.
So we already got quite a few.
Yes. I can tell it's a lot of his doctors, a lot of Indian doctors, I think, a lot of Indian doctors, Indian neuro residents.
Yeah. Yeah, okay, I think he's here.
Good.
Hi.
Hey, Dr. Goel.
Hello.
Good morning. Good evening.
Good morning. Good afternoon. Good evening. Good night. John, how are you?
I put the beach here for you just to make you feel relaxed when you came. Okay, Ipe hasn't arrived yet. Let me see where he's at. So the internet situation's always been that way, right? Hot and cold with you, Dr. Goel?
Yeah. Yes, John?
Yeah, the internet comes and goes, huh?
Yeah, that's the problem.
Yeah.
Hello, Atul. This is Ravi Ravindra, your uncle from Canada.
Oh, my goodness.
Best wishes.
Nice to see you online, Uncle, and I'm happy to have you on board. I hope you will enjoy this session. This is going to be on technical neurosurgery, not on philosophy and meditation and yoga and other things. I wish that you can also talk to this illustrious gatherings someday and give your wonderful sessions on yoga and meditation and philosophy and other things.
Well, that may not be relevant to your present situation, so I will shut up. Okay, listen to me.
Okay, Dr. Goel, you ready to start?
Yeah, I'm ready. I'm
Okay.
ready.
Okay, let me just make an announcement. We're not started yet, but everyone on the panel, please stay muted. And if the internet does go down, like it did yesterday and the last couple of days, just be patient and hang in there. Dr. Goel will do his best to jump back in as soon as he can. Okay, 10, 9, 8. Oop, I'll start my count again later in a second. Hope he's putting on the souped up button. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Miami Beach, the home of Neurosurgical TV. Here's the beach in the background. We have the honor of having Dr. Atul Goel, well-known neurosurgery master educator from India. And we're going to go right into it, Dr. Goel. Welcome and thank you for coming.
Thank you, John. Just let me get the slides in.
Okay. Everyone, please mute, please.
I'm going to talk to you today on a very important neurosurgical subject, which I feel is quite neglected. Arteriovenous malformations are difficult neurosurgical problems. It may not be wrong to say that it might just be that arteriovenous malformations are impossible neurosurgical problems. I am going to discuss with you my personal thoughts about how to handle arteriovenous malformations. Basically, I am going to talk to you about the status of surgery in the management of AVMs. And this is based on my experience with 525 surgical cases. So basically, my concept about AVM is, about treatment of AVM is that either we should not treat them or we should treat them by surgery. So these are the two ways to handle AVM. And there are a number of AVMs where actually there is no treatment necessary. And surgery is necessary, or surgery is the best option in the other half of the patients. So it is for the surgeon to decide whether surgery will be possible or surgery should not be done. Now, this is the AVM, and this is the AVM nidus. Nidus may be of different types, and the type of nidus actually determines whether surgery is possible or surgery is not possible. So I'm showing you some nidus. This is the nidus in the region of motor strip. This is a little bit largish nidus in the frontal brain. This is in the parieto-occipital brain. And this nidus is fed by large feeding vessels, and there is a feeding artery aneurysm. If you ask me how you determine whether you will be able to operate or not, and what is the character of AVM which makes it what it is the nidus. And the degree of flow of blood in the nidus. Even small niduses can have very furiously high flow in them. So the degree of flow in the AVM determines whether you will be able to actually do the operation or you may not be able to do the operation. So how you determine the degree of flow in the nidus? One is by the size of the feeding arteries. Second is by the size and the number of draining veins. And more importantly, to find out how the degree, how fast the blood is flowing, you should actually go and see the angiography being done in the DSA room and see how fast the blood is going in the AVM. Some AVMs are big and diffuse, and there is no possibility of any kind of surgical treatment that you can see in the MR. Multiple niduses are quite uncommon and rare, and this is one example. AVM nidus fed by large vessels are relatively easier to operate. AVM fed by multiple small vessels are relatively more difficult to operate. And of course, the site of AVM, you see this is in the dominant hemisphere in the speech area, so it is a much more difficult problem. So I made a grading system of mine. And this grading system is when I see the angiogram, when I see the DSA, and I see for myself, yes, it is possible for operation, or is it easy for me to operate? Is it difficult? Or whether it is safe or not? Is it very difficult and risky but possible? It is not safe or not possible. So this is a classification that is for me. And it will differ from me to someone else and from anybody else. And more importantly, as I grow in my experience in AVM surgery, maybe today it is very difficult. If I become good and better, it may become difficult. It may come to this stage. So this is a very dynamic kind of staging system or grading system of AVM, which is very highly personalized classification of AVM. Of course, the characters of AVM, like size of the AVM, location of the AVM, number and type of draining vessels are all very important to understand the type of AVM and whether it will be safe or not. But this is my personal grading system. AVM surgery has developed over the period of time. To the extent I may say that the degree of aggression in AVM was much more 20 years ago or 25 years ago, as we are having more alternative options in the treatment of AVM. We are dependent more on radiosurgery and embolization and things like that. The number of surgeons probably treating AVMs has probably gone down. And the confidence in the young neurosurgeons in handling such absolutely bleeding situation can be much low. So more importantly, for the surgeon, it is absolutely important to identify whether he will be able to operate this AVM. And this decision, whether he will be able to operate or not able to operate, he has to make before operation. He cannot start the operation and then make the decision, because once it starts bleeding, you cannot stop. You have to control the bleeding and then you have to come out. Means it is not a situation where you can take decisions during the operation. You have to decide, yes, I can do it, or no, I cannot do it. So this decision has to be made on the basis of your information that you get on the radiographic images. As we all know, the quality of imaging has improved in the last 2 decades quite dramatically. And this angiogram, you see how beautifully the AVM is demonstrated, and the location of the AVM, the relationship with adjoining structures, the relationship with ventricular cavity, which is so important to understand before operation, the number of vessels feeding the AVM, the number of veins draining the AVM are seen so beautifully. So this information about the AVMs was not available earlier. This is another angiogram. As you can see, the AVM, and this model we made for the first time, we made a model of AVM on the basis of radiographic images, actual 3D model, which we can hold in the hand. So this model was our first generation model. We have, of course, improved on this model. This is the AVM you see inside the ventricle. It is absolutely critical to know whether the AVM is inside the ventricle or outside the ventricle. Inside the ventricle, AVMs are relatively easier to operate. If the AVM is outside the ventricle, it is much more difficult or maybe impossible to operate. So this information you can get on the basis of MRI, and this fiber tracks, you can see how the fiber tracks are displaced along the ventricle outside the AVM. So you have the exact information about the corpus callosum fibers, about the motor fibers when you are going to operate. So this imaging is a very important imaging for deciding as to whether to operate and how to operate. So we introduced 3D model printing for the first time in the literature. This is the AVM, and you see how the AVM is there. And this is the 3D model. And this model shows you exactly where is the AVM and how is the AVM in relationship to the skull, the nature of draining vessels and all. You can correlate with this. Now, recently, we have even color-coded this AVM, where red will be arteries and blue will be veins and things like that.
You're muted there, Dr. Goel.
We
Hold
can't
on,
hear
let me
him.
Hold on, let me see if I can unmute him. Okay. It's something with the system. We can't hear you, Dr. Well. We can't hear you.
This is with me,
Yeah, with you now. Okay.
John?
Yeah, we can hear now.
Okay.
We can hear now.
Yes, yes. So this is the 3D model. And you can see the AVM. Just a minute. This is the 3D model. So you know exactly where is the AVM, and you can see the AVM and identify the location on the skull, this AVM, and then plan your surgical strategy. Now, surgery on AVM is difficult. Surgery on AVM can be impossible. And surgery of AVM is not easy. So your planning is very important. And of course, there are some special techniques in AVM surgery, which I'm going to talk to you. This is another model. You see, this is the 3D model showing the extracranial arteries and things like that. And this AVM was certainly, of course, not operated. Now I want to show you some AVMs and how to decide and plan for surgery. When the patient comes to you, you see the patient and you see the massive symptoms that she's having. She's having severe headache. She's not able to, even when the person is headache does not mean that you operate. If the person has giddiness, it does not mean you can operate. If the person comes with convulsion, it does not give you a license to operate. The license to operate comes to you in hand only when you feel and when you think that you can operate and you can successfully resect this AVM. Then only that is the license. Patient does not. When this patient came to me, you see the very high flow AVM. Now you have to take the decision in this young girl whether to operate or not. Even if she is having headache, she's alive and she's there. You cannot create hemiplegia in this patient. You cannot create a deficit in this patient. You cannot say, let me try. If you are reasonably certain that you can remove this AVM, which is a very big AVM and very high flow AVM that you can see, and this is the 3D model that we made, and then we operated on this patient. This is intraoperative ICG monitoring that we did. And you can imagine this is a huge AVM, and that decision whether I will be able to operate or not has to be very, very carefully monitored, because you operate and it can be a very big disaster. During the operation, if it bleeds, sometimes it may bleed here. You start here, it may bleed here, it may bleed here, and it may bleed so furiously that it may be absolutely difficult or impossible for you to hold. And it may bleed from 1 point, from 2 points, from more than 2 or 3 points, and it can create a very disastrous surgical field. So you have to control the bleeding. You have to go around the AVM, and you have to control your own self. You have to identify before operation how to come to the AVM, whether you have to come from lateral side, whether you have to come from medial side, which artery to take first, which artery to take next, which vein to avoid, and which vein to be kept till the end of the operation. So all these technical issues have to be planned and perfected much before you enter into the theater. So planning is very important. More important in AVM is your surgical exposure has to be huge. Your exposure in this case should be from here to here. It's a massive, big exposure. Minimal invasion is not possible in AVM surgery. This is postoperative angiography, where it shows that the AVM is completely resected, and you can see a very beautiful smile on this patient's face. If you do a good operation, if you are able to successfully remove this AVM, you give new life to this girl. You give absolutely new life, and the person is without symptoms. And this is not a malignant issue. This is not cancer. The person is cured. So there is a possibility of completely curing the person. There is a possibility of completely ridding the patient of the AVM, and this person will lead a normal life. On the other hand, any surgical complication can create hemiplegia or aphasia or things like that, can be a very big disaster and a lifelong disaster that the patient will not be able to handle, and the relatives will not excuse you for their lives. This is another huge AVM you see. Now the question is whether you can do it. Now this person has come with the only complaint of giddiness. Now giddiness is the problem. For the complaint of giddiness, for the problem of giddiness, do you want to do this surgery? That is the issue. Now this patient comes to me, a young boy. I said, no, this is not possible. This is tremendously dangerous. There is no convulsion, never actually really bled, and a very high flow AVM that you can see. And this AVM has been resected, and this boy is completely all right. He came back later and said, doctor, my headache is too severe. My giddiness is just too much for me to handle. And we took the risk and we operated. Of course, as I mentioned, it is not the patient's consent that matters. It is not the patient's complaint that matters. It is what matters is your ability to be possibly able to remove this AVM. That is what matters. And I want to show you how to handle this situation. This is another quite a huge AVM, and this AVM is also very high flow AVM in a youngish person. This is not a meningioma that you remove it en masse or things like that. This is not a tumor that you can remove it piecemeal. This is not a tumor where you can do a partial resection. This is not a tumor where you can say, I will remove half now and half in the next phase. This is an AVM. Partial resections are the most common cause of AVM disaster. Just a minute, please. Partial resection is the most important cause of surgical disasters or post-operative disasters. You cannot do half resection. Once you enter into AVM, you have to win the battle of bleeding and you have to come out. Of course, as I mentioned, you have to plan very appropriately these large vessels. Interhemispheric exposure is very important key in these AVM surgery. You have to come and first get these vessels and then surgically circumferentially dissect this AVM. And these models are one of my key investigative method now, and I do it for all formidable AVMs. So this is the post-operative angiography, and this is the AVM, and this has been resected. See, what I'm trying to show you is that success is, of course, gives you a certain kind of happiness and great gratification, but any kind of disaster can be a lifetime disaster for the person. This is another AVM, and you see the location of the AVM in the region of great vein of Galen, in the vicinity of the brainstem, supplied by multiple vessels, location in the depth and drainage with the straight sinus and multiple veins in this area, and the person is not dramatically symptomatic. Now the question is, do you want to do it? And if the person has significant symptoms of giddiness, there is no other way to treat other than deciding on surgery. So when you think about such AVM, there are some good points in this AVM that you decide on when you see the angiography, and some bad points like location in the vicinity of brainstem and things like that. You have to identify what are the good surgical points, what are the negative surgical points. AVMs fed by the PCA are relatively good surgical issues. So interhemispheric exposure, come and first get the PCA and then get to the AVM is relatively a good surgical indication. Interhemispheric exposure and first get the anterior cerebral artery feeders is a good surgical parameter for you to decide the possibility of surgery. So you decide, and here surgery was decided, and post-operatively you see the angiography showing complete AVM resection. Patient coming with a massive bleed and in a difficult condition, and this is the AVM. You see here also, if you see, my good surgical point in this case is a large PCA. When I see a large PCA, my interhemispheric exposure and getting to this vessel is relatively easily possible. Getting to this vessel and then getting interhemispheric exposure and then removing is relatively easily possible. Now, the other issue that I want to talk to you about is when the person has bled, do you want to operate immediately in the immediate postoperative phase or a delayed postoperative phase? Earlier, I used to wait for a period of 3 months or 2 months for the brain to settle. But now I take my decision because, sometimes these patients are in hemiplegic patients and this hemiplegia will improve. But, this gives a kind of a surgical safety for you. In case the person develops hemiplegia, you can have some kind of safety. So in that regard, now I like to do rather early post-ictal surgery on these cases. And this is the postoperative angiography in this particular patient. Now this AVM, as you can see, is relatively common site of AVM. If you see this AVM, the PCA is the dominant artery, and this gives me a surgical kind of a certain kind of ease of surgery and certain kind of safety of surgery because relatively benign area of the brain. But this AVM, which I am showing, is a very high flow AVM that you can see because it is fed by the posterior circulation. It is fed by the middle cerebral artery. It is fed by the anterior cerebral artery, and it is sucking blood from the contralateral circulation as well. So in my definition, the number of feeding channels to the artery, to the AVM, are a good indicators of the vascularity, the flow, the degree of flow to the AVM. So the number of vessels feeding, the size of the vessels feeding. So this was a massively high flow AVM, which made it very difficult to operate. But of course, this was surgically a very beautiful case to operate, and this was successfully done. And this is the AVM. This is the postoperative angiography. Now, what I want to do is I want to show you one AVM and little bit of a surgical video. So this is an AVM which has come with bleeding. You see quite a large bleeding, blood in the fourth ventricle, AVM in the region of anterior circulation, region of anti-communicating artery, large intranidal aneurysmal dilatation of the vessels is also one indicator of very high flow situation of the AVM. And this is the AVM. Now I want to ask the panel whether you will like to operate on this patient or not. So if you want to operate on this patient, you have to find out what are your good points for the surgeon and what are your negative points for the surgeon. The location in the vicinity of the anterior communicating artery and anterior cerebral artery is a bad point. If you take one vessel, you kill the person. So most important issue in AVM surgery is to identify normal vessels from abnormal vessels. This is the whole operation is based on this. You cannot take one normal vessel. If you take one normal vessel, you create a big disaster. So this is the AVM and this is the surgical video. And I want to just show you, and by the time the video is running, I will just talk about the AVM. Now, this is the AVM in the location of the anterior, like ACOM artery aneurysm. Your exposure has to be very big. So you see my temporal lobe is exposed, and my big and wide exposure is the key to this AVM surgery. And for that matter, for any AVM surgery. Wide exposure, control of the AVM in your hand. This is the optic nerve. John, can you see the video? John.
Yes, we can.
Is the quality okay, you think?
Yes. It's
Okay.
good.
So this is the optic nerve. Now, before the operation, I have to plan how I will expose the ipsilateral A1, how I will expose the contralateral A1, how I will expose the internal carotid artery. All these things have to be absolutely under control. So here, this is ipsilateral optic nerve. This is the contralateral optic nerve. So you see I am completely elevating the brain off the skull base. And then this is, of course, a little bit edited version of the video. But I must also tell you that you have to little bit hurriedly go into your process of operation. Most important is the experience in identifying normal blood vessels from abnormal blood vessels. Any vessel that bleeds usually is abnormal. Don't coagulate unless you are forced to coagulate. That is another very important issue in AVM surgery. Don't coagulate unless and until you are absolutely sure that you have got the right vessel. I like to first identify the normal vessel from the abnormal vessel. Once the largest feeding vessel is identified, I have to coagulate and then cut. Both these things have to be done. Coagulate and then cut. Initially, some large vessels, I like to have a silver clip placed like I had placed in this patient. So this is a large, huge venous dilatation of the AVM. Of course, you will not handle the large dilatation in this manner on a routine basis. You have to be very sure that it is not going to blast on your face like an aneurysm. There must be some issues in this AVM that I am holding and manipulating in this fashion. Large feeding vessels have to be identified and then cut, and then the AVM has to be circumferentially dissected. Progressively, the AVM has to be dissected off from the adjoining brain and adjoining normal vessels. And this has to be done progressively, aggressively. You must know that it may bleed. It may bleed from one point. It may bleed from more than one point at one time. And sometimes it looks good when you are operating. Sometimes these can be a good medal for you, like gratification, a huge success, and you can be very proud that you have done a very great case. But sometimes this can wither off. In no time, the bleeding may start from here, the bleeding may start from there. You have to deal with large blood vessels, you have to deal with medium-sized blood vessels, and you have to deal with small blood vessels. If you ask me what is the trick of AVM surgery with you, my trick is the identification and control of small blood vessels. Small blood vessels are the key in AVM surgery. And as I go further in this AVM, I will like to show you how to handle small blood vessels. If you think small blood vessels can be controlled by Surgicel, you cannot do AVM surgery. If you think small blood vessels can be controlled by pressure, you do not know what the AVM surgery is. Small blood vessels, to identify small blood vessels, and these small blood vessels lead you to the large draining feeding vessel. So the small blood vessels are the key. Small blood vessels need not be coagulated. They are a marker for you to, they lead you to the big blood vessel or the feeding mother vessels. Leaving small blood vessels is a sure shot disaster. Small blood vessels should be identified. Mother feeding vessels should be identified and coagulated, and that until the time you get completely white, no rest in the AVM is not removed. When with AVM resection, you will find not a drop of blood coming from anywhere in the business. When you find small vessel bleeding at some point, that is the point you should explore, and you should deepen your dissection, go identify the feeding vessel, and invariably you have left some AVM behind. So at the end of the surgery, you will find a complete hemostasis, and that is the parameter of AVM resection. So this AVM, you see this AVM has been resected, and believe me or not, you have given new life to this person. This new life is without fear. This person can live full life and normal life. He's not having a malignancy. You see the A1, you see the contralateral AVM, A1, you see the ACOM, intercommunicating artery, and you see the whole AVM dissected. And these were the large feeders. So this is post-operative image. You see the entire AVM is gone, and this is the post-operative CT angiogram, which I do in all cases, and this is the AVM after surgery. So this is a technical success. You can be very proud when you do such a formidable looking AVM successfully. But I have to tell you that to do such AVMs, you have to be an absolutely confident surgeon and to be ready to take the challenge. This is another AVM in the Sylvian fissure. Sylvian fissure AVMs can be quite dramatically dangerous. They look more dangerous because in the Sylvian fissure, the normal blood vessels look like AVM blood vessels, and they can give you a very dramatically difficult difficult view. You see, this is the 3D model, and this is the angiography. You see the largest veins in this area. So I want to quickly show you the little bit of a video of this patient. Now this is the large AVM. Most important is to have a very high degree of confidence that yes, this can be done. That is very important in any neurosurgery. But in AVM surgery, if you do not have that confidence and you do not have that experience, you might land into a very difficult situation during operation. But also I must tell you, the AVMs look bad on angiogram. And during operation, when you enter into this task of removing the AVM, they may not look all that formidable. And you can actually get into the field and in the business of removing this AVM in a rather not such impossible kind of a terrain. Identify the feeding channels. Preserve the veins till the last. I am not saying that all the veins can be preserved till the last. Once you have the handle on the AVM, once you have taken the large feeding vessels, you can take some veins. It is not that you have to preserve the veins till the end of the operation, and if there is a vein damage, that is the end of the situation. It is not like that. Most important is that in this Sylvian region, you should not be taking any normal middle cerebral artery vessel. If you take a normal middle cerebral artery vessel, you can have a situation where you land up with complete AVM resection and with complete hemiplegia. You do not want that situation. You do not want means if you have that situation, patient will never be happy, the relatives will never be happy, and they will never allow you to be happy. All their life, they will trouble you. You cannot create disaster in AVM surgery. Because these patients, like if you create a disaster in glioblastoma, this patient is in any case going to not survive for several months or years. But this AVM person will be surviving. You must remember this. So you have to do a good job, and that is what is important, because either you let the person live with severe headache and all those things. Now the question is, in this situation, you will ask me whether you like to do embolization, preoperative embolization. Now to answer that question is, I do not like to have preoperative embolization. That is the answer. On the other hand, there are several AVMs that come to me which have been preoperatively embolized. I must tell you, the preoperative embolized patient does not become a completely safe or simple operation. It is, on the other hand, a little bit more dangerous or trickier for me. So this is another AVM. You see, huge AVM. You see the entire brain is AVM. The one thing which is absolutely crucial to understand in this huge and mega AVM is that they are high flow AVM. Large AVMs are always very high flow AVMs. And in large AVMs of this magnitude, they almost always have a feeding vessel from the ventricle. And that ventricle bleeding is most furious bleeding. So this is the AVM. Now you have to decide. This is another AVM where the symptoms are not very huge. The symptoms are not, the person is not unconscious or not hemiplegic before operation. Person is walking. Person is having severe headache. Now you have to decide, yes, I will operate on this. And this decision of surgery was taken. When the decision of surgery is taken, you have to be absolutely, completely in your own control. So this is the AVM. My first attack is near the anterior cerebral artery, like the ACOM artery aneurysm. I go in this, the brain will not be tight. Brain is not hugely tight in AVMs. AVM is a chronic situation. Of course, when it has bled, it may be tight. So first, what I'm doing, of course, this image is not so clear, but just what I'm doing is I'm trying to go in this base of this AVM, trying to identify the main feeding channel of this AVM and putting a template on the feeding channel. Then I will dissect more and more in this area to get to the feeding vessel. This video, of course, is not such good quality. You must remember that I am under quarantine. I'm locked down in my house, and I cannot go and get a whole lot of videos from my department at this time. So whatever I had in my house, I am showing. So what I'm trying to do is, this large AVM has some very nice and good points for the surgeon. You see, it has a very small base. And I am trying to get the feeding channel early in the operation. And once I get this small base, the whole pyramid I can handle. But I must tell you that this is not just the point of feeding point of this AVM. There are multiple feeding points all over the place. As I have mentioned to you already, I don't like preoperative embolization, wide surgical exposure, getting to the feeding vessel early in the operation, prepared to handle bleeding from 1 point, from 2 points, from more than 1 point at a time, 3 or 4 points, the whole field loaded by blood. You have to be prepared, and your surgical team has to be prepared to handle that kind of a bleeding situation. There is no excuse. And I must tell you that in certain situations, you might find yourself in such a difficult situation that you would regret your decision of surgery. getting to the large vessels, then getting to the small vessels, and then dissecting the AVM is the trick of the trade. Coagulation at the right point, coagulation of the right vessel. Don't coagulate a normal vessel, because you coagulate a normal vessel, that may be the end of the operation. You have to dissect the AVM circumferentially. Temporary clips I use, but when I'm sure that this is the feeding vessel, then I use these Liga clips, or small, we used to call them earlier silver clips. But now these clips are no longer silver clips, they are titanium small Liga clips. Get the feeding channel, cut these vessels. Then come circumferentially dissect. And I must say that this is a rather straightforward, this is not such a greatly difficult AVM. But no matter what, all these AVMs of this caliber, this size, do have a feeder from the ventricle, and they have more than one feeding channel. You see this gradually, I have got the AVM in my control, and then I will circumferentially dissect this AVM. And as I have mentioned, this AVM was not such great difficult AVM. Huge AVM, but a very favorable location in the frontal brain. Small and thin pyramid of AVM where you get the feeder. But you must remember these AVMs can be quite dramatically, here also you have to, large bleeding is not shown in an edited video. These are edited videos. More importantly, what must have been shown here is the point where I am in the control of the AVM, where I am in a fear of losing control and losing the patient.
Tool, are you there?
Okay, yeah, sorry for that.
Okay.
So did you see I want to ask are you seeing the AVMs?
Go
Yeah, we are
ahead.
seeing it. We are seeing it.
Thank you.
Okay, so this is now almost the AVM is dissected. So now what I'll do is I'll go to the next AVM. This is another issue. You see here, this is the AVM which has been embolized. Many of these patients come to me when they are already embolized. So I have got quite a good experience with embolized AVM. To answer that question again and probably again, I have to say that if the AVM, this is a virgin AVM, I do not like preoperative embolization. If the AVM is embolized already, I do not mind it. But I have to tell you that it does not make my operation terribly easy or terribly bloodless. This is my personal experience. I know no other person who is doing AVM surgery will actually agree to this, but this is my personal opinion, and I do not do preoperative embolization if the person has come to me first. So this is another AVM which has come to me embolized, and this AVM has been beautifully resected, and this patient is completely cured. On that, you see, as what I want to convey the message to the young audience that I have today in front of me is that there is a possibility of curing these people. There is a possibility of giving them completely new life. Intermittent embolization, partial embolization, coming repeated episodes of repeated sessions of embolization. I am not particularly very convinced about that kind of treatment. I am not saying, and you must not get this idea that I am saying that all AVMs can be resected or should be resected. You have to decide which AVM you want to do and which you do not want to do. This is another very formidable case that I am going to show you. This person, this young, not very young, about 50, 55 years old lady, coming with this huge AVM. And this patient also had very severe giddiness. Means she was not able to even stand because of her giddiness. And this person also, I said that no, this is too risky a case and I do not want to operate this. You see the jugular vein is massively dilated. The superior vena cava is massively dilated. And this is a very high flow AVM. But this lady comes to me again and says, doctor, no, this giddiness, I cannot live with this giddiness, you operate. So we ultimately decided to operate. I operated this patient 15 years ago. In this AVM, if I have to operate, I have to decide what are the good points for me. You see, this is a good point for me. I can very easily go to this anterior cerebral artery and get this feeding vessel. Then I have already told you the PCA. The PCA feeding vessel is very good point for me. I can come interhemispheric, get to the PCA vessel early in the operation. That is a good point for me for surgical decision making. You see huge superior parietal sinus venous drainage, huge multiple aneurysmal kind of venous dilatation. So I'm going to quickly show you some, because this is a very old video of my surgical steps. I will like to show you interhemispheric exposure is the very important key to this operation. Interhemispheric. For a majority of large, huge AVMs, they are fed by the anterior cerebral artery and by the posterior cerebral artery. And interhemispheric exposure is a very important surgical strategy. So, you know in the interhemispheric exposure, there can be large venous drainage, that vessels that you have to avoid. You see there's a huge superior parietal sinus here that you have to take under control. This AVM is quite under the brain. Video, of course, is quite an old video, but you see just what I want to show you. Interhemispheric exposure. First identify this large vessel, anterior cerebral artery. Then get control of large vessels, medium-sized vessels, small-sized vessels, and I must tell you, it will bleed. It will bleed, and it will bleed furiously at times. But you have to have that confidence in getting the control of that bleeding. It can bleed from more than one point at one time. And sometimes in these high flow AVMs, you can start getting a feeling that you are losing it. And actually, I must tell you that you can lose the patient during the operation. The blood loss may be so furious and quick. You may not be able to control the situation, and you may actually lose the person during operation. But you have to confidently go on dissecting, get to the main site, get to the feeding channels, get to the draining channels, avoid, you see here what I'm doing is avoiding the superior parietal sinus and the drainage. And of course, I'm not able to show you very clearly what is happening in this AVM. So what I'll do is I will just rapidly terminate this operation here. And this is the AVM that has been in the last. You see how it is on the superior sagittal sinus and the vein I'm actually ligating at the end of the surgery. So this is a surgical success. And this is beautifully resected, and for 1 month, it will leave you happy. It will leave you in a situation where you are walking not on the ground, you are walking high on the ground because of this surgical success. And this is the patient comes to me after 1 or 2 years of surgery, and this is the AVM, which has been completely resected. So what is important in this AVM is that you have completely given a new life to this person, completely. This person is free of giddiness, this person is free of AVM, and this person is normal person now. The question that I am against posing before you is, let me show you the AVM again. This is the AVM. Symptom is only giddiness. Radiation is not going to be successful. Repeated embolization can be successful. I'm not saying embolization is completely useless or things like that. But embolization has its own tremendous risk. And you may be completely creating a complication without touching the AVM. My recommendation will be, if you can do it, you see there are some beautiful points. This anterior cerebral artery is so huge. You come interhemispheric, get to the feeding vessel. You can have half the AVM under your control. Then go to the posterior cerebral artery. This is the second thing that will come under your control, and circumferentially have the confidence to dissect this AVM. And they are resectable, as you can see. This is another very high flow AVM, which was resected quite successfully, and completely this person is cured. This is another AVM, and I will give you my disaster in this case. This AVM was referred to me by a politician, and repeatedly that politician was saying that you are the best surgeon and this and that high, and this is in the motor strip AVM, and this person has come with complaint of multiple convulsions. So this is a motor strip AVM. Now, whether you want to operate this or not, but you know,
slide.
I operated this person. And also this AVM has several good points. You see the anterior cerebral artery is so big. So I have the confidence of coming here and getting this vessel first, then this vessel first, and then deciding. And many of these motor strip AVMs are not that dramatically difficult. They are quite safe, and it does not mean if the AVM is in the motor area, don't operate and all. This is not the thing. Many of these AVMs are much easily dissectable. And this is the post-operative, but this patient developed post-operative hemiplegia, even when my exposure was interhemispheric. But of course, this patient recovered to an extent, but never completely normal. But this patient is having no convulsions, and this patient is without AVM, but this patient is having significant hemiparesis. Progressively, such hemiparesis after AVM surgery, they will improve. I must tell you that post-operative hemiplegia, after a glioma, you make hemiplegia, that patient may not improve. Post-operative hemiplegia following brainstem surgery may not improve. But post-operative hemiplegia after AVM surgery will improve over the period of time.
Okay, just hang in there. Ike, are you there?
Yes, John, I'm here.
Yeah, you want to use this time while we're waiting for Atul to get back?
Well, let's wait for him to get back. What we can do is we'll wait for 5 minutes, and after that, I'll tell him that maybe Pablo can start because it's already 6:15 right now. So
Okay,
let's wait for him.
okay. Oh, okay. Okay, let me see. Pablo, are you there? Let me next you.
I'm here.
Oh, hi, Pablo. Do
Hello.
you want to, I just heard from my people. Let me see if that's a tool now. And the tool, is that you coming back in? How you doing, Pablo? I'm Dr. Bennett.
Okay, perfect.
Okay, I guess we'll start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hi, this is Dr. Bennett, broadcasting from Miami Beach, Neurosurgical TV. We have the second part with Pablo. Pablo, I have a hard time saying that. Alea from Argentina. Welcome, Pablo, and it's all yours.
ये अब नया लेक्चर शुरू हो रहा है.
Hello, thank you, John. Thank you, Ipek, for the invitation. Everybody's
Thank you,
hearing me?
Yes, let me just mute a few people here. Yeah, all set, Pablo.
Okay, perfect. So I will try. Let me see. Give me 5.
Okay.
Let's see why I cannot share.
There you go. You're on the
Here we
way.
go.
You're on the way.
You can see now the presentation.
Yes, I can. Hey,
Okay, I can start now.
Hey, John,
Okay.
please put Ipe on the panel.
oh, okay.
Yeah.
Hello?
Yes, go ahead, Pablo.
Okay, perfect. I will start with vestibular schwannomas. I have no conflict of interest. And everybody knows that acoustic neuromas, the treatment of acoustic neuroma has evolved dramatically during the last decades. So now total tumor removal and good quality of life post-op has become the general acceptance treatment goals. So what are our objectives in this type of surgery? We have to do total removal. We need no fascial palsy in the post-op, and if you can, preservation of audition, especially in small tumors. So how can we do this? Well, we need first to keep calm. We need time, a lot of time, and perhaps something of talent, less like Messi have. Everybody know him. So let's go to the anatomic knowledge. It is very important to go to the lab and follow the principles of Professor Roton. That is very, very important. So let's talk about surgical technique in this type of cases. You can see now, this is an anatomical dissection from my friend Alvaro Campero. And you can see here a subtemporal approach. This is used by the ENT surgeons. And here you can see the internal auditory canal open by the middle fossa, the trigeminal nerve here, the middle meningeal artery here, and the superior petrosal here. And you can also do a transpetrosal, posterior transpetrosal approach for this type of tumor. And you can see it here in this anatomical, again, the presigmoid approach. Here you can see the fascial nerve. Or you can do a suboccipital approach. This is the approach we prefer for this type of tumors. There's a lot of published papers about this, which is the best approach for this type of tumors. But we think that the retrosigmoid approach seems to be the most versatile corridor for this tumor, because you can preserve better the fascial nerve, and you can operate all type and all size of tumors. There are some disadvantages that are described in the literature. I don't see too much of this, but it is associated with higher risk of pain and CSF fistula. You can see here the anatomy of the posterior fossa skull base, just to see where these tumors are settled. And you can see here the petrosal vein, the trigeminal nerve, 6 nerves, 7 and 8 here, the posterior wall of the internal auditory canal was drilled. And here you can see the 9, the 10, and the 11. And in this anatomic photo, you can see also B3 segment of vertebral artery and B4, and you can see that the pica is extradural. This is not very, very frequent. So that is the area we have to go and take out the tumor. We always monitor our patients, especially always the 7th nerve and the 8th nerve with brainstem auditory evoked potentials. And if the tumor is very big, we also monitor brainstem. We use the park bench position. This is the position to operate these tumors we use. We never use a semi-sitting position. And you can see that we divide the ear in 4 parts, so we can know exactly where is the sigmoid and the transverse sigmoid. Now we have to expose this area here. So this is the incision. This is the position we use, as I told you. And it is very important to know all the anatomy of the neck very well. We published this article 2 or 3 years ago. So you can know exactly where is the vertebral artery, where is the suboccipital triangle. If this is more useful for far lateral approach, not too much to suboccipital, but it's a very useful article to know where the muscles are. So this is the exposure we have to get. And here you can see the lambdoid suture here, the emissary vein, and the digastric growth here. We have to expose this. This is the exposure. Then we can do a craniotomy or a craniectomy, but it's very important to expose the transverse and the sigmoid sinus. The border, you have to expose it in order to make a better surgery and to expose better the tumor. And this is the way I open the dura. I prefer to open it this way because with this cut here, I don't have to then, when the surgery finish, suture here, very close to the sinus, and we have a risk there of bleeding we finish the surgery. So we prefer to do this type of approach. And this is a photo to explain that if you have to operate this type of tumor, for example, a peripheral nerve tumor, I said, okay, you have to operate it with this approach. It is impossible. You have to expose everything. So when you operate a vestibular schwannoma, you have to expose, not always, but practically always, everything. So here you can see in this anatomical view, the 7 and 8 here, the ICA here, 9, 10, and 11 here, the petrosal vein, and you can see these lines here that finish here. When you have a huge tumor, sometimes it's difficult to find the posterior wall of the internal auditory canal. So you can make a line there. My friend Alvaro published this many years ago, 10 years ago, a dural landmark to locate the internal auditory canal in giant vestibular schwannomas, the tubing line. So you can see here in a surgery, a big tumor, we have to take out all the cisternal part, and you can see there the line. It's very useful to locate the posterior wall of the internal auditory canal. So this is what you have to do in surgery: take out the bone there, expose the tumor inside the internal auditory canal. This is, we analyzed practically 100 patients many years ago. You can see here, 97 patients operated. Most of the patients were T3 or T4, because we do not operate T1 and T2, only when they grow. And we operate all T3 and T4 patients. This is the Hanover classification of tumor size. And you can see that most of the patients have poor hearing or anacusia. So in order about hearing preservation, we use again the Hanover classification. And you can see that in big tumors, hearing preservation is low. It's more difficult to preserve audition in big tumors. It's more easy to preserve than in small tumors. And this is the post-op facial nerve palsy. You can see that we have very good result, practically 70% of House-Brackman 1 and 2. And this is, we make total removal in 92%, practically 93% of the patients. We have 7 patients with big tumors that we leave a small piece of tumor over the facial nerve because it was attached, and we have to cut the facial nerve to take them out. And in 93 patients, we get an anatomic preservation of facial nerve again. 3 patients with CSF fistula, all treated with lumbar drainage. Only one patient reoperated. 2 post-op hematomas, and we have 1 death of pulmonary embolism. I will show you now some examples. We published this. This is the Latin American, it's in Spanish, it's the Latin American Journal of the Federation of Latin American Societies. And I will show you first a T2 schwannoma, small tumor. I operated this tumor 3 weeks ago. And you can see this is a 60-year-old patient with good hearing. The tumor was growing. So we decided to operate. You can see here, small tumor with practically no tumor inside the internal auditory canal. You can see here in the MRI. So what we do first is we take out CSF, as you can see here. We expose the tumor then. You can see here the internal auditory canal. Here, perhaps the 7th nerve. This is up, this is down. You can see here the 7 and 8 tumor. So we first stimulate the nerve, so to be clear that is the 7th nerve. So then we open the tumor, we coagulate and open the tumor. We always do the same in this type of tumors, as you can see. And with the ultrasonic aspiration, we start to debulk the tumor. The tumor is small, but we debulk the tumor because it's more easy to remove, to move the tumor. And you can see there the trigeminal nerve here. So we are taking out some attachments there. Here, the lower cranial nerves, we do not touch there, nothing. And then we continue with the ultrasonic aspiration, as you can see. And we dissect the tumor from the brainstem. Here is the trigeminal nerve, brainstem here, 7th nerve here, lower cranial nerves here. You can see that there's arachnoid there because we do not touch them in order not to have a paresia in the post-op. We try to operate with huge magnification. And you can see that we dissect the tumor from the brainstem, and now we are taking out the tumor from the 7th nerve. We try not to coagulate there in order to have a better result in the post-op facial nerve palsy. We dissect the tumor from the 7th nerve there. As you can see, we take out that tumor out. And when we start, and we said, okay, we have to drill the posterior wall of the internal auditory canal, we noticed that there's not too much tumor inside the internal auditory canal. So we try to do a maneuver there. And look, the tumor comes out very easy. So we take out all the tumor out now, as you can see. With good preservation of facial nerve, you can see here, 7 and 8, internal auditory canal, lower cranial nerves, brainstem, trigeminal nerve here. There you can see the 6th nerve here, and this is the final view. Let's see one T3 schwannoma. This is a 52-year-old patient with anacusia. And you can see the tumor here in the pre-op MRI. Pre-op MRI, the tumor, 2 centimeters practically. Here we have more tumor inside the internal auditory canal. This is the way we open the dura, as I told you. As I show you in the anatomic view, we first take out CSF. In small tumors, we just open the cisternal, the cistern. We do not go to the cisterna magna. In big tumors, we open the cisterna magna. Now we are monitoring. Sometimes the facial nerve is posterior, so we have to monitor previously. So then we coagulate, open the tumor. And as I show you in the other case, this is bigger, but we start with the debulking. So we can move the tumor and take out the part of the capsule, and then we continue debulking. And when we think we finish with the debulking, we continue with the debulking. Here is the petrosal vein. So this is up, this is down. Here the lower cranial nerves. There you can see the trigeminal nerve from the brainstem. This is brainstem, and here we can see the facial nerve. We are monitoring now. You can see there the 7th nerve. So we find it in the brainstem. Then we go to the internal auditory canal and we remove the posterior wall, as I told you. This is the way we open the dura there, and you can see tumor inside the internal auditory canal. So we take it out. We take all the tumor out here, and then we take time to take all the tumor out, to dissect the tumor. Here is the problem when you dissect this type of tumor. There is a place where the facial nerve goes to anterior, and you can cut it here. So here you have to take care. You have to use the ultrasonic aspiration a lot in order to dissect a small piece of tumor from the facial nerve. And this is what we do. I can skip a little bit here. So we are finishing with the excision here. We take out the tumor there. And you can see we are dissecting from the facial nerve. We take time for that, trying not to coagulate there. And we take, this is the final view when we take the rest of the tumor. You see the preservation here of the facial nerve. Here is the place, the complicated place. We put a little bit of muscle in this case, fibrin glue in order to prevent fistula. And you can see this is the post-op MRI, and this is the patient in the post-op with no facial palsy. We have permission of all our patients to show these photos. And now another case, there's a cystic part here, anterior, and again the same. We expose the tumor, we take out CSF. You can see that we are not using retraction now. We use the monitor. We identify that the seventh nerve is not posterior. We open the tumor. We start with the debulking, and more debulking, and taking out pieces of tumor so we can see the anatomy. We continue with the debulking, as you can see here. Debulking, controlling bleeding. And here we start to move the tumor, as you can see. Again, dissecting the upper part. Here is the tentorium. And here you can see petrosal vein. If we don't need, we don't cut the petrosal vein. We try to preserve. As always in neurosurgery, you have to preserve everything if you can. And continue with the ultrasonic aspiration. And here we can see the brainstem, petrosal vein here, trigeminal nerve now, brainstem here. So we do the same that with the small tumor. Here you can see lower cranial nerves here. Skip a little bit. Now we move better the tumor because the tumor is the bulk, so we can move it better. Here the internal auditory canal. Here you can see the lines I told you. Now we take out all the tumor in the brainstem, so we go to the internal auditory canal. We drill the posterior wall there, as you can see. We take the tumor out, and then we go again and do the same I show you in the other case. And this is the final view. You can see the facial nerve perfect here, and we put a little bit of muscle there, fibrin glue. I don't do this now because I have some problems in the post-op MRI. Sometimes it seems to have tumor there. You can see the post-op MRI, patient posterior in the post-op, patient now, 3 months post-surgery. I will show you now a T4, a big tumor in a young girl. You can see huge tumor, T4, with compromise of the fourth ventricle. You can see here with tumor inside the internal auditory canal with anacusia. So here the exposure is a little bit more difficult, but we first do always the same. We stimulate, we open the tumor, and we start debulking, and more debulking with ultrasonic aspiration. And when we debulk a lot of tumor, we start moving the tumor and taking it out. So here you can see we need time for this big and huge tumor. Here is the petrosal vein, but we still have tumor there. So we start moving the tumor from the upper part of the tumor. I prefer to move it from there because the facial nerve, it's generally in the lower part. So there we continue with the debulking, and you can see there the brainstem and the trigeminal nerve. We continue with the debulking, We take out here, we have just opened the posterior wall of the internal auditory canal, so we take out the tumor, we stimulate to see if the seventh nerve is working good. And then we start dissecting the tumor from the facial nerve. This is, we need time for this. We need a lot of patience. You have to take care with the nerve, because this is the patients want to preserve. The facial nerve is more important than everything for patients. And here we are finishing the dissection and taking the tumor out, as you can see. And this is the final view. No tumor, opening the posterior wall of the internal auditory canal, a little bit of muscle there again. And you can see the post-op MRI. Here is the facial nerve. You can see there's a little, here perhaps small piece of tumor there, but the patient do really, really very well. This is the post-op facial nerve, nothing. And this is 3 months post-op with no facial nerve palsy. Let's go to, this is another case, very huge tumor. I will show you only the pre and the post-op. I don't have the video of this case. Big tumor, immediately post-op MRI, but we do the same I show you in the last case. And you can see the patient in the post-op and the patient 3 months post-op with no facial nerve palsy. I will show you some different cases now. This is a cystic schwannoma. In cystic schwannomas, it's more difficult to preserve facial nerve. You can see here, cystic schwannoma. Patient in position, incision, exposure of the bone. And I show you the surgery. You can see that we open the cyst and we take that liquid out of the tumor. We are dissecting here the lower cranial nerves, as you can see here. This is the tumor, here the tentorium, here lower cranial nerves, internal auditory canal here. So we do the same, we stimulate, and then we start with the debulking. The debulking in cystic tumor is more fast because you don't have too much tumor. So as you can see, we continue this section and we find this nerve here is the vestibular nerve. We stimulate it and it was not the facial nerve. So we coagulate here and cut this nerve. This is the vestibular nerve. So we free the tumor, cutting here the vestibular nerve. And we continue dissecting here. Here, yes, we can see the facial nerve here. We try to make the dissection very slow with magnification. There you can see the trigeminal nerve here, in the upper part of the tumor, the petrosal vein here. And then we go to the internal auditory canal. You can see here the line. We expose the posterior wall of the internal auditory canal. We drill it. We take out the tumor inside the internal auditory canal. And then we continue with the dissection, trying to take all the tumor out. And we take all the tumor out. And this is the final view. We put again muscle there with total resection. And here you can see the post-op MRI and the patient with a facial nerve palsy here, because as I told you, cystic tumors are more difficult to preserve. I'll show you some difficult cases, strange cases. This is a case with an ICA over the tumor. When we open, you can see in the pre-op MRI, nothing to show about this find, a 21-year-old female. And you can see when we open, you see the ICA here over the tumor. We have to preserve it. So what we do in this case is we leave a piece of dura attached to the ICA and we dissect it with the dura. And then we try to dissect the artery over the tumor to get like a window to start taking out the tumor. This takes time. So we continue with the dissection of the artery. And then we start taking out the tumor. I skip a little bit. We do the same. We stimulate, then we open the tumor, then we start with the bulking again. And then the same here is the upper part of the tumor, petrosal vein here. Then we take out the tumor inside the internal auditory canal. Sometimes the ICA is in the bone and we have to drill the bone. And then we finish, we put muscle again. The artery goes to the brainstem there, we move it. And this is the pre and the post-op. This perhaps is a little bit of tumor, as you can see here, perhaps it's the muscle, I don't know, but we have 5 years of follow-up, and this is the patient in the post-op with no facial nerve palsy. Now, we publish a classification of the ICA because of the subarachnoid artery complex. This is embryological development, because if the subarachnoid artery is short, the ICA is over the tumor. If it is long, so the ICA is not over the tumor. This is another case to show you air cells in the posterior wall of the internal auditory canal. You can see the MRI. This is a cystic tumor. And if you don't ask for a CT scan, you never see this. So you have to ask for a CT scan in this patient, not only MRI, because if you open this and then you don't shut these air cells, you will have a fistula in the post-op. So in this case, what we do is we take out the tumor, as I show you in the other case. The bulk, we move, we preserve the facial nerve. But what we do when we finish the surgery is we take out the cistern part of the tumor, and here you can see the facial nerve emerging from the internal auditory canal. And what we do is we use the endoscope and we take the tumor inside the internal auditory canal with endoscopy assistance. So we don't have to open the posterior wall in this case. Here is the endoscope. I don't have the video of the endoscopy, but I show you the post-op MRI with no tumor. So this is, you can use endoscopy when you have this type of different anatomy. This is another case with hyperostosis over the posterior wall of the internal auditory canal, and you can see here, this is a patient with neurofibromatosis, and you can see these two tumors, these big tumors, the big tumor with hearing preservation in this side, a small tumor with no hearing in this side. So we start with this tumor, but you can see here in the CT scan, there's a lot of bone there. This is patient positioning for surgery. And you can see when we open, we see this huge tumor here that we cannot take out the tumor. So we start drilling. So in this case, we drill first. We take out that bone. And we take out the bone in the internal auditory canal. Then we make the same I show you. This is stimulation, the bulking, moving the tumor. As you can see, we use stimulation all the time, and then we finish. Here is the seventh nerve is going here. You see it in the video. We preserve it very well, and you can see this is the post-op MRI, and you can see the patient with no facial palsy. In these cases with schwannomas in both sides, it's really important to preserve facial nerve. Really important. About complications, I show you 3 complications. I will show you one. You can see this small tumor, and you can see the final view of the surgery, 7 and 8. Here the trigeminal nerve, here the petrosal vein, everything perfect. But it's very common with this patient, the post-op arterial hypertension. So you have to take care of this because it's very, very common. And we can have an hematoma in the post-op. And a small hematoma like this make that these patients stay like 2 or 3 months in the ICU. In this case, we have black, the patient have black and do very well. You can see the patient 3 months, 4 months post-op here with no facial nerve palsy, but he have a ventricular drainage and stay in the ICU a lot of time. Many authors talk about the bulking and radiosurgery for these tumors. But if you see the literature, you can see here the systematic review and meta-analysis of subtotal resection And longer-term follow-up said, and larger patients are necessary for fully evaluate the rate of tumor control. So I don't think this way is a good way to get a good tumor control. And you can see in this paper about quality of life in this patient with gross total or less than gross total and radiosurgery that the patient don't do well. So I think the best way to get a good quality of life in the post-op is total removal. And you can see here that there's many papers also reporting success rate for treatment of vestibular schwannoma with radiosurgery, but it's unclear how these tumors grow. So they think that success is no growing of the tumor. We have a lot of tumors, small tumors that never grow, and they don't have radiosurgery. So I think we have to take care about radiosurgery in vestibular schwannomas. And you can see this also, an aneurysm caused by radiosurgery, an ICA aneurysm caused by radiosurgery. So we have to take care of indicating radiosurgery for all these tumors. And you can see this is a Cochrane library, and you can see there is no high quality evidence in the literature from radiosurgery to determine whether stereotactic radiotherapy is better than microsurgical resection or observation alone. So take care with radiosurgery. So when many authors said that the bulking and radiosurgery, it's because they don't want to operate. They don't want to go and take the risk. They don't want to learn. They don't want, so they send it to radiosurgery. It's more easy. I indicate also this only for very old patients or with a lot of comorbidities. So the best way to preserve the facial nerve is to see it and preserve it, not to leave a piece of tumor over the nerve. You only need time. You only need to practice. So as a conclusion, and I'm finishing now, the goal of acoustic neuromas treatment should be total removal in one stage and preservation of neurological function. This goal can be safely and successfully achieved using the retrosigmoid approach, in my point of view. The results demonstrate that if we carefully establish educational plans in skull-based surgery, excellent clinical and functional results can be achieved. You can see more videos here in my YouTube channel, and this is my mail. If anyone want to contact me, I can answer all the questions. I think that there's a lot of comments here, but I cannot answer them now.
Okay, Pablo, thanks a lot for a great presentation, and we'll open it up for briefly for some comments or questions for Pablo. Yeah,
Okay.
I'll get you off the screen share there, Pablo.
Yeah.
Hold on, let me get it off there. Okay.
Perfect.
Okay, we're open for questions or comments for Pablo. People will step up. Go ahead.
Thank you, Professor Pablo, for the presentation. Very kind from you.
Hello, Manuel.
Hello, Professor. Thank you so much for the presentation.
Thank you.
Hold on, H. Pablo, Manuel's asking a question. Go ahead, Manuel.
No. Just want to thank Professor for sharing his time on this moment for all of us. Thank you.
Sí, otro español, está en Rusia.
Yes, hablamos español.
Rakesh patient છે ને Rakesh.
Okay, H, you're on. Go ahead.
ને
H.
છે ને આપણે ટ્રેન બંધ કરજો અત્યારે. હા.
Go ahead, H. I'm sorry, didn't get the question.
નાનું તો પતી ગયું. હવે જે તરુણ છે તરુણ એને ફીવર આવી ગયો તેવું ગયો છે ને.
I'm sorry.
બ્લડ ચાલુ કર્યા પછી આવ્યો તો.
I need translation for that.
Yeah, I do too. I don't know, but I don't think it's Spanish. I can't even identify the language.
I'm sorry.
આ તો કઈ નહીં જોવો નહીં.
Can you try again and speak slowly, please? Hello? Okay, other comments, questions? Okay, I know it's a little awkward, this platform, but people will get used to it eventually. It just takes a little. Go ahead, A. Go ahead.
I want to ask you, when do you use external ventriculostomy in this kind of patients?
That's an excellent. That is an excellent question because I want to talk about that. I never use it. I never put a shunt in this patient. I go and take out the tumor. When you take out the tumor, the hydrocephalus resolve. Sometimes, maybe you need. I talk about ventricular drainage in the post-op in that patient that bleed because it makes an acute hydrocephalus. So I put a ventricular drainage. But during tumor removal or previously, I never use it.
Okay, very good.
Thanks.
Thank you for the question. Any more questions, comments for Pablo?
Hello.
Go ahead, Avinash, go ahead.
Hello, sir. If patient is having bilateral tumors, like in neurofibromatosis 2, which side do you operate first? How do you decide on that?
Can you repeat the question, please?
In patients having bilateral vestibular schwannoma,
yes.
Which side do you operate first? How do you
I decide to?
Well,
in that case, I prefer to operate the site with no hearing because the patient have good hearing in the other side. I was waiting the hearing to go down, and when it start going down, I operate the other side in order trying to preserve audition.
Okay.
But you never have you never have the 100% of possibility to preserve audition. So maybe the patient start doing a lip lecture, you know. So then
yes.
When you take out the other tumor, you put a brainstem implant.
Okay. For the second operating on the other side, how many what will be the time duration between first surgery and second surgery?
You need to wait 3 months between one
3
and
months.
the other surgery. 3 months minimum, but you can wait more. You can do it in 6 months or 1 year, no problem, if the patient is doing well.
Okay, thank you.
Very good, thank you. More questions, comments? Step up. Now's your
Hello.
chance. Go ahead.
Hello.
Go ahead.
Sir, till what level you drill posterior to IAC? Do you calculate it in pre-op CTs? And my second question is, before attempting the removal of tumor, what like if you encounter cerebral edema, it will be so difficult for retracting. So how do you manage those patients?
About retracting and cerebellum, when sometimes it's difficult to get in and the cerebellum gets a little bit damaged, the thing I do is I open the bone more inferiorly and go and open the magna cistern. I never cannot enter if I do that. If I open the magna cistern, I take out CSF, I wait, I take a little bit more, and the space start to open. It's very important, the position of the patient. That's very important for that, and it's very important, the anesthesiology. These two things are also important. I'm sorry because of my English, it's not very good, but
No, you're perfectly understandable.
okay, perfect.
Okay, more comments or
And
questions?
there's another you make another question. I don't remember the first question.
The first question was, till what level you drill posterior to IAC? Do you calculate it in pre-op images, pre-op CTs? Do you calculate it like till? No, you don't. Okay.
No, I don't calculate nothing.
Roughly 10 mm behind posterior.
Don't calculate nothing. I go.
Cystic schwannomas recurrence chance.
Cystic schwannomas are more difficult because the problem is not the difficulty to take it out. Take it out is easy. The problem is the facial nerve in cystic because the tumor is very attached to the seventh nerve. So it's very difficult to take it out. You have to take time, but sometimes you lose the seventh nerve in that cases. So you have to be very. I prefer to, in this case, sometimes if the patient is very young, to preserve small part of the capsule there.
Okay, thank you, sir.
Thank you.
We have a
Sir.
question from
Hello.
Musana Ashfaq. We have a question. He says, instances where you opt for CSF diversion post-operatively, any incident of facial nerve injury, and how do you manage if yes?
Perfect, perfect. CSF diversion post-op, perhaps in a patient with bleeding, and we have a acute hydrocephalus and don't resolve with the external drainage. I put a CSF diversion in that cases, only that cases. Never put a CSF diversion previously to the surgery with a big tumor. I try to take out the tumor. And about facial nerve injury, that is a very good question, because if you lose the facial nerve during the surgery, you can do some things. Yeah, I prefer to take out one. I make a graft there. I would try to make a graft, to put a graft of nerve there and put a fibrin glue. I would take the graft from the leg. That's what I do.
Hello.
Okay, Javez, go ahead.
I want to ask how much milliampere can you use to stimulate the facial nerve, not to injure the facial by stimulation? How is the maximum? How much the maximum?
Well, you know, we use our stimulator is an IM response, a Medtronic, and you can put it up. No, nothing happened with the facial nerve, but I try to use it very low, very low, in order to know that the facial nerve it's okay. Because if you put it very high, sometimes you get a positive response, but the patient wake up with a total nerve, facial nerve palsy, no? So I try to use it very low.
Thank you.
Okay, Peru asks, do you do anything different if patient has a preoperative facial paresis, like a grade 3 facial palsy?
If the patient has a pre-op facial nerve palsy, I would think that it is not a schwannoma. It is a meningioma or another tumor, because that's very unusual. But no, I would try to preserve. If it is a schwannoma, I would do the same. I would try to preserve, then wait, perhaps the patient improve, and if it not improve, and I have a facial nerve palsy, a total facial nerve palsy in the post-op, I will wait, and if the patient don't recover, I will go and do a reconstruction of the facial nerve. I like the Sawamura technique for doing that.
Okay, we have a question from Dr. Harshal Agrawal. Do you use lumbar drain during surgery?
No, but it can be used. I never use it.
Okay. Muhammad asks, if you encounter a petrosal vein that is in the way, what is your policy on preserving it?
Well, I will tell you something about petrosal vein. If you're operating a tumor of the posterior fossa, meningioma, schwannoma, you can coagulate it and cut. Because when the tumor grows, the venous drainage change. So that patients, maybe you can cut the petrosal vein with no problem. The problem is when you cut the petrosal vein and you don't have there's a lot of children talking there.
Yeah. Okay.
When you cut the petrosal vein, for example, doing a trigeminal nerve decompression, sometimes you can have problems there because the tumor is not there and the venous drainage don't change.
Okay, a question. What is your suggestion to a very large T4B schwannoma without any CSF on cistern surrounding? And how about the craniotomy? Do you think we need far lateral approach so we can expose more space and CSS drainage enough? Thank you.
It depends of the surgeon, no? I never do far lateral for these tumors. I think if you don't have space, maybe in that cases, it never happens to me, but perhaps you have to take out a little bit of cerebellum to reach the tumor and start the bulk in the tumor. And when you start the bulk in the tumor, the CSF will go there, because there's always CSF in the magna system. Maybe you have to, if you have an important edema of the cerebellum, you have to take it out and make a bigger craniectomy, or not craniotomy. Maybe you have to do that in that cases. The important thing is to take out the tumor, and if you take some part of the cerebellum, nothing will happen to the patient.
Okay, very good. More questions, closing questions?
There's another question there about
Okay.
semi-sitting position.
Okay.
No, sitting position, it's okay. I like it. I operate some tumors in the sitting position, but I prefer the park bench because I'm more comfortable. There's no another fact to decide that.
Okay, you see any more questions there, Pablo? I can't see.
Yeah, there's another question about internal arterial canal drilling. I never do it first. I always first make the debulking of the tumor, take all the tumor that I can out, and then I go to drill.
Okay, we have Dung Gaga, the neurosurgeon from Nigeria. Do you ever consider using other approaches besides the retrosigmoid?
No. I do the transpetrosal anterior and posterior for other tumors, but not for schwannomas. For schwannomas, I prefer this approach. I learned from here. We have a lot of influence of Sami from Hanover, and we saw him many times. And our school here is to operate by that approach. You can do it with the approach you want. Important is the result.
Okay. The role of pre-op DTI imaging to locate facial nerve?
That's beautiful for presentations. You can do it, but you know, only once I find that the facial nerve was posterior, but I do stimulation. That's what I think.
Okay, what pole of the tumor is tackled first?
What part of the tumor?
What pole of the tumor is tackled first?
I go first to the superior part, because I'm far from the lower cranial nerves, and when the tumor shrink and is smaller, I go to the inferior part and dissect it from the lower cranial nerves.
Okay, Dr. Harshal Agrawal asks, a lot of talk in scientific meetings are on the eighth nerve preservation. Do you have any comments on that?
If you want to, I show you the first case. I show you a small tumor. There are some things you have to take care there. You have to try not to coagulate nothing. Small arteries you have to preserve. You have to dissect. Maybe some big surgeons in this, like Marcos Tatashiva, use papaverine in order to dilate arteries and preserve audition. Maybe it helps. I never use it.
Okay. Okay, Uday asks, which part of the tumor you start first after your initial debulking is done? Is it lateral part near the IAC or near the brainstem?
No, I first go to the brainstem. I decompress the brainstem. I identify the facial nerve there, and then I go to the other part.
Thank you.
There's another question there. If the opening of the internal arterial canal is very big, you can make a dural flap. Yes, Guta Naibajo asked that. You can put fat. I prefer fat for that cases and fibrin glue. That's okay. And they asked me also about the use of endoscopy. In all cases, no. In all cases, no. But sometimes, if I have a doubt, I have the endoscope there in the operating room, and I use it. I use a lot of endoscopy. I do a lot of transnasal approaches, so I always use the endoscope.
Alessandro Deandra asks, which ultrasound aspiration do you prefer for the schwannoma?
There's there are some articles talking about that, about preserving the vascular, the arteries. You know, I never put the focus on that. I use the ultrasonic aspiration and I see if the aspiration is doing well and going up or down. But no analysis of that. I'm sorry.
When do you prefer the pre-sigmoid approach?
For petroclival meningiomas. That's where I use the pre-sigmoid approach. Only petroclival meningiomas, not for schwannomas.
Okay, do you close the dura or leave it open?
No. We always close it in it, trying not to prevent the fistula.
Okay, do you see anything
Linear.
else?
Well, regarding the incision, I always use linear, but incision is not important. The important thing there is to take out the tumor out and preserve the seventh nerve. You can do the incision you learn. U incision I saw in the United States. I see there's a lot using a U incision. Some big tumors, big surgeons use a U incision, but I prefer linear.
Okay, very good. More closing comments or questions? You've answered a lot, Pablo.
Yeah, there's a lot of questions. Yes.
Rapid fire. Okay, very good. Okay, I'd like to thank you very much, and I hope you do it again.
Thank you, of course.
Shortly.
No problem.
Okay.
Thank you, Sean. Thank you, Ipe, for the invitation.
Okay. Tenemos charlas cada sábado en español también en Neurosurgery.
Bueno, salud. Hasta luego. Suerte.
Okay, yo
Take
voy a
care.
hablar contigo. Okay, gracias.
Bye-bye.
Okay. Okay, I think we're gonna continue with Atul. Atul, you want to continue your interrupted presentation? Are you there, Atul?
I'm waiting for you, my dear.
Okay, here we go. We're ready to roll. Go ahead.
All
Let's
set.
continue on.
Yes. Can you see that, John?
Yes, yes.
Okay, so now back to blood and back to bleeding and back to danger to life and back to danger to limbs. This is one AVM that you see in the motor area. And this patient has come with a bleed. And this patient has come with hemiplegia. Now I want to ask you what you will do for this patient and when you will do this patient. You see, when this patient has come with hemiplegia, it is not such a big bleeding. And this patient will certainly improve after 2 or 3 months after surgery. The question is whether you want to wait for 2 months to remove this AVM, if at all you are thinking of removing, or you want to remove in the immediate postoperative period. Earlier, I used to wait for 2-3 months, but now I prefer to do it as early as possible because it gives you a kind of a safety for the surgeon because hemiplegia is already there and you may not be blamed if the hemiplegia persists. However, that is not the way you think about. You want to improve this guy and you want to give him a new life, but these motor strip AVMs are formidable surgical problems. MEP, motor evoked potential monitoring may be helpful. I don't do it often, but in some cases I would like to do. This is another motor strip AVM. You see this AVM with large aneurysmal dilatation of the draining channels. And this is very likely to bleed if you leave it. And of course you have to remove it, but you have to remember that you can create a very big person. But I have to tell you that many of these kind of motor strip AVMs have a very good plane of dissection and the arterial feeders are very well defined and you can come one after the other, get to the feeder and then you dissect around the AVM and you can remove this AVM. So these are motor strip AVM, of course, look very formidable when you look at the MRI and when you look at the AVM and you see such large devastating vessels. But the question is, if you don't do, then there is a big possibility of this getting ruptured and the person dying. But if you do it and you remove it and you have a normal angiogram after surgery, you give completely new life. So it is a matter of here and there, matter of death versus life. Maybe this patient may live normally without any symptoms for quite a bit of time. Maybe he has headaches, maybe he doesn't have, maybe he has convulsion, but there is a possibility of bleed. But the thing is, there is a big possibility of surgical resection and curing this person. This is another motor strip AVM, as you can see, and this is the AVM resected, and this is the boy you can see in my hand. And you see there is a small drift in the left hand, but I'm sure he will improve over the period of time. Now you will ask me what cases you will operate, when is the good indication to operate in the motor strip AVM. Like for all AVMs, there are some good points and there are some bad points. And that the surgeon has to decide for himself which are the good points and where he will go and how he will go and whether he can go or whether he will not be able to go. All these issues have to be decided. And as I already mentioned, these large AVMs usually have a ventricular supply, and this ventricular supply bleeds at the end of the, nearing the end of the surgery. And this is a very big bleeding, and this can be a dangerous point during the operation. This is another AVM you see in the region of interhemispheric fissure. Interhemispheric approach is a very common and very relevant approach. This patient has come with bleed, and you have to come interhemispheric to resect this. And you see this bone model. And this model is giving you exact information as to where is the venous drainage, where is the anterior, and where is the location as regards this head. You can make a very beautiful exposure in this interhemispheric areas, looking at the bone and looking at the three-dimensional 3D model. I'm not talking of 3D image. This is a 3D model which you can place in your hand. You remove this AVM, and of course, this is not such a dangerous AVM to remove. This is another AVM in the interhemispheric fissure. I will rate it as not very difficult AVM because you come in the interhemispheric fissure, get to the anterior cerebral artery early in the operation, and then the rest of the story may not be all that difficult. But I should not ever use this word simple or easy or not dangerous. All these AVMs can be heavily dangerous. All these AVMs can bleed very tremendously during operation. Most important than not, you have to have, not a pseudo confidence, not a hyper confidence, but a real kind of confidence and of course experience in doing such cases. This is the AVM you see here, this AVM, and this AVM is right in the middle of the head. So there is motor evoked potential being monitored here, and according to the location you design your surgery, the flap. So these 3D models are very good, and this is the patient. So we had described for the first time in literature contralateral interhemispheric approach. So this is the AVM, and if there are large draining channels here, so coming from here may be a little bit dangerous. So you can come from here, get to the anterior cerebral artery feeders from here, and once you have got the feeder, you can come from here. So bilateral. So contralateral interhemispheric approach we have described, but you can have a bilateral interhemispheric exposure to resect these tumors. This is another very formidable tumor that we had done long time ago. I do not remember how this patient was, but there is some good points you can see in the velum interpositum it is going. In the drainage, in the great vein of Galen and straight sinus, you see how big is the straight sinus, but there are some very beautiful points in this. There is a big anterior cerebral artery, there is a big posterior cerebral artery, and there are feeders from the choroid plexus, and this is a very compact kind of nidus, and this is the post-operative image of this case. This is another huge AVM. And of course, this is when these kind of huge AVMs, these are all high flow AVMs, and they have multiple feeding vessels. This is like quite a bag of worms, but these are not so benign worms. They are quite aggressive worms, and they will of course, they will bleed. So your planning, your execution, and your termination of the operation, completion of the operation, handling of the big vessels, handling of the small vessels, handling of the medium vessels, all these things will matter. And when you are going to remove such a huge AVM, and you must remember that all these patients may have potential issues and there can be complications. This is post-operative AVM. See, you remove it, you completely cure the person. Any kind of deficit, I have already mentioned, any kind of small deficit or big deficit is not tolerated by the person. This is the tumor, this is the AVM in the motors area, in the speech area. And this person has come with the only issue of convulsion. Now you have to decide, and multiple convulsions. These are such small feeders, you cannot do. Whether you want to do radiosurgery in this case may be a good option in this case. But in this patient several years ago, I preferred to operate and remove this AVM. No more convulsions. Also, regarding convulsions, I have to state that you operate for convulsion, you remove the AVM, it does not mean that the convulsions are gone for good. Convulsions may still occur. So you have to inform the patient beforehand. One is that you can have a big problem after surgery. Second is the convulsions may still remain. So you have to decide whether to operate or not to operate. But of course, if you do it beautifully, the convulsions may completely go. This is another huge AVM you see in the interhemispheric fissure, large feeding vessels from the anterior cerebral artery, huge venous aneurysmal dilatation, and you have this is another AVM, big AVM, and this patient was a nun, which I operated in a private hospital. Nun, and when I was operating, the whole hospital was full of nuns with all in their dresses. So it was a difficult situation for me. And as I have, it is not without complication. You see the entire middle cerebral artery is going here in this AVM, and you could have a situation where it is all or none for you, but you have to decide whether it is possible or not. But this was, and of course, you have to execute it with great precision, great microneurosurgery, dissection, and circumferential dissection. This is the boy I had operated several years ago. I had only angiography. We used to do, of course, during those time, only angiogram. And you see this AVM, and this AVM is entirely dissected. This patient developed post-operative hemiplegia, but this hemiplegia recovered. As I mentioned to you earlier, hemiplegia, if they happen after AVM surgery, more often than not, they recover. If you have a hemiplegia following brainstem surgery or tumor surgery, may not recover. But AVM surgery, hemiplegia, or any kind of hemiparesis, most likely to recover, and you have actually cured the person. This is another AVM. You see, this is a dramatic AVM. And you must remember that what I'm showing you are some of the more complex cases in my series. I'm not showing you exactly very simple AVMs. And just to show you that even, all the AVMs that you will see will not be of this caliber or this size or this intensity. What I'm trying to show you is even difficult, dangerous looking AVMs can be removed. And many of these AVMs will be very small AVMs in the frontal brain. So you must not have a feeling that AVM surgery is not an option. Surgery is a most wonderful option even in these kind of formidable cases. Only the thing is that you have to be very sure of what you are doing, and you cannot create a complication. Of course, complications happen in our business of neurosurgery. Complications happen all the time. Disasters happen all the time. But you must remember that you are here to cure the person, not to create disasters. But disasters, if they happen, you cannot just break your head over the disaster. And you have to learn from that disaster, and you have to improve in the future. So the essential message is that you can do AVM surgery, small AVMs. More often you will get small AVMs. These, of course, what I'm showing you are more dangerous AVMs. This is another posterior fossa AVM. You see the parieto-occipital AVM, and it's large posterior PCA territory feeder. And this interhemispheric, posterior interhemispheric, come here, get this feeder, and get this AVM. I will not rate it as a very highly dangerous AVM or a difficult AVM. This AVM I had operated several years ago. This was a mathematician and from interior of India. And several surgeons have said no to him all over the world. And this gentleman was also embolized repeatedly, and you see several aneurysmal dilatations on the AVM. And this AVM was removed beautifully with multiple clips. Now the question comes as to what to do with these aneurysmal dilatations if you find. Many of these aneurysmal dilatations will be on the feed channel that you have to get along with the feeding channel, but you don't have to specifically go for the feeding if it is far away from your field. Many of the people who are doing endovascular surgery recommend that these aneurysms can be embolized and coiled. But in my situation, in this situation, this case, which I have done several years ago, nothing was done to the aneurysms, and all these aneurysms after the removal of AVM ultimately thrombosed. This is another AVM which is posterior circulation. AVMs are relatively easier to deal with because of the cerebellum, which can handle manipulation much better than other parts of the brain. And you can come in the brain, superior cerebral artery, ICA, PICA, and gradually remove this AVM. And this is postoperative image. Intraventricular AVMs are also relatively easy, much more easier than other AVMs. Intraventricular AVM, you enter into the ventricle, and then you can it is not such a difficult, except for the fact that they are in the center of the brain. Exposure may be difficult, your complete exposure may be difficult, but these are arising mainly from the choroidal vessels. You get good exposure, interhemispheric exposure, or whatever exposure you have to have, and then you remove this AVM. This is temporal horn AVM. You see this AVM, and this is the choroidal vessels feeding the AVM, and this is postoperative, immediate postoperative angiogram showing resection of the AVM. This is velum interpositum AVM, come with a bleed, quite a big bleed. You see this velum interpositum. So you have to have, you see, you either say, okay, I don't want to operate, or you should operate. My recommendation will be, look at the angiogram, find the good points and find the weaker issues, and then get your anatomy correct, because these are completely precisely anatomical operation. Your anatomy should be absolute. Your control, your hemostasis has to be absolute, and this is the postoperative angiography after removal of the velum interpositum. Now, this is the AVM. The more important and the more crucial issue in this AVM is whether it is intraventricular or extraventricular, whether lenticulate arteries are supplying or choroidal vessels are supplying. So that you have to identify absolutely perfectly, because if it is choroidal vessel, it is straightforward. If it is lenticulate artery vessel, it is a dangerous and difficult and not to be done AVM. So this AVM is by choroidal vessel, and this is the, you can see the angiogram choroidal vessels, and this is the AVM after resection. Intraventricular AVMs, and this is the postoperative angiography. This is another case that I had done successfully, but this patient had come quite unconscious after a big bleed to me. I had removed this AVM, but this patient never survived after. But this was quite a fantastic surgery, as you can imagine. There are some good points. There are some hugely bad points. You can see the very high flow nature of this AVM. I would have normal situation. I may have taken decision whether to operate or not, but this patient was in quite a bad clinical condition. I thought we should operate, and I had done this. And this is the preoperative angiogram. You see quite a formidable one. I will not, I must remember that I'm showing you the more dangerous case. This is the AVM which has been removed. But this patient, as I mentioned to you, never survived. Now, this is one case which I am showing you, and I want to ask you whether it is easy or whether it is difficult. And I have to tell you that it is not difficult at all, because this is not AVM. This is a pile AV fistula. There is a large vessel coming here, and the fistula is here. You take this vessel and the whole thing can disappear in a very fantastic manner. This is the preoperative, looks very formidable. You see the venous drainage in the superior parietal sinus, and this is the AVM. And I will like to show you the video of this case, but let me get to the video. Unfortunately, maybe I leave the video here. So this is the large pile AV fistula. You must remember that these are not dural fistula. These are pile AV fistula, arteriovenous fistulas. These are not AVMs. If you just coagulate this, finish this vessel, the whole thing is finished. I wanted to show you maybe at the end, because it is in my computer other file. I'll show you probably at the end of the operation, end of the presentation. And this is not, so this you must remember that looks very dangerous, but it is quite a safe and beautiful. You try to embolize this. You see, you come and embolize this vessel. That is also an option. You come and from the venous circulation you put is quite a big amount of material you will have to put. But I think surgery is the most beautiful and convincing way to come and close to the fistula and completely finish this artery. So this is the, I don't think the video is here. I will show you at the end. And this, the whole thing I had removed at that time. I must tell you, at that particular time when I removed this pile fistula, I was not exactly knowing what are pile fistulas, but pile fistulas are different from AV fistulas, and pile fistulas are different from arteriovenous malformations. And the strategy of resection, you may not, and there may not be any need to resect the whole mass, but they become, once you take the feeders, it becomes like a completely beautiful plane of dissection. This is another pile AV fistula. You see, you just get this feeder, and I had removed this pile AV fistula completely. I am not sure whether this removal is necessary or not, but it is quite an easy task once you get this arterial feeder. This is another pile AV fistula. You get this feeder and you remove this AVM and you get a beautiful postoperative angiography. Another pile fistula you see here. These are large, the fistula you have to identify. And once you get the fistula, you disconnect the fistula and the matter is closed. This is another fistula, pile AV fistula. You see the feeder you have to identify. So pile AV fistula is a very beautiful entity that many neurosurgeons do not know very nicely because they are relatively rare. But in vascular malformation, pile AV fistulas are relatively straightforward clinical entities to be operated. This is the post-operative, and this is the whole fistula has been removed. So I had published 14 cases some years ago. Now we have several more. So many of these AVMs, as I have shown you, can be resected, but there are a huge lot still which cannot be resected. And in that situation, I will recommend that you do nothing. So you, in this kind of diffuse nidus, I will say there is no possibility of treatment. The long-term natural course is better than any kind of treatment. There is no radiation. There is nothing that can be done. Even when this kind of diffuse thing is there, you attempt any embolization or anything, you can create very big disaster. So in this situation, I will recommend that no treatment of any kind is the best form of treatment. Thalamic AVMs, and see, this is a thalamic AVM. Long time ago, I had not operated on this, and I still think that such AVMs may be better suited for either no treatment or maybe if at all radiation treatment. I don't know about that treatment, but radiation may be an option in this situation. AVMs which go into the brainstem are dangerous and according to me are not surgical issues. AVMs outside the brainstem are good issue, can be possible, but inside, if they are bled inside or if they are going inside, can be dangerous issues. This AVM also I considered without, at that time, not for surgery, and I left it. It's another huge AVM which I did not touch. So in short, what I'm saying is there are many AVMs that are beyond my range or beyond range of surgery, and you have to decide, yes, possible, no possible. This is brainstem bleeding inside the brainstem, I will not operate. Now the question is whether embolization is good for you or not. I mentioned to you, I do not like embolization. It helps in surgery. I don't think it makes a difficult surgery easy. AVM surgery is a difficult surgery. AVM surgery is the last chapter of our subject. Here we need philosophy. Here we need understanding. Here we need to know the patient very nicely. Here we should know how the patient will fare. We should know our own level of expertise and confidence, whether we can remove. So many issues. So I say always that AVM is the last chapter of neurosurgery. You have to do it, this chapter. After you have finished all other chapters, you have to come to AVM. Whether partial embolization is good for you, I don't think really. And also there can be potential complications. This is one AVM which was embolized repeatedly, and then there was a huge bleed. So AVMs can bleed by embolization. You see, this was a relatively straightforward AVM, but it has bled, and then I removed it. You see, there is a lot of blood in that AVM. Another AVM, you see, this was embolized and embolized repeatedly and repeatedly embolized multiple times. You see, you must also remember, I don't want to criticize any form of treatment. Interventional radiology has improved. Interventional radiology has gone several miles ahead in the business. Interventional is a revolution in our subject. Interventional radiological procedures are good in several indications. But in AVM, interventional radiological procedures are still controversial. There are issues about arterial access, venous access. I have heard several wonderful presentations where venous access has been found to be successful. But there are the controversies regarding interventional radiological procedures for AVM are still very huge and heavy. But I am having a feeling, considering that such great difficulties can be posed during operation, you can create a disaster and death in the postoperative period. You can create hemiplegias in the postoperative period. I am having a feeling that after 5 years or 10 years or 20 years, maybe other adjuvant kind of treatment may be possible. But today, if you ask me, if you can operate, that is the best. If you cannot operate, then there is no need for any kind of treatment. Half-hearted treatment is not a good treatment. So this patient, as I was mentioning, was repeatedly embolized till the time he bled. And then in a bleeding situation, he was almost dying. I went and removed this, but he never survived. So my dear friends, thank you very much. I hope you enjoyed this journey and the world of AVMs. This is a very beautiful world. This is the world of neurosurgeons. You cannot ignore this world. You cannot leave it for adjuvant treatment. You cannot leave it for others. It is our business. We have to learn and do it. So thank you very much.
Okay, thank you, Dr. Goel. Excellent. Let's open it up real fast. Okay, questions and comments, please, from the panel. I can start. Kumar Abhinav asks, sir, what do you do for perfusion pressure breakthrough syndrome after a high flow AVM resection?
Now, this is a question which I am repeatedly asked. Perfusion pressure breakthrough concept. And if I have to answer this concept, I will say that I do not believe in this concept. My concept is you have to remove the AVM completely. What happens is if you have left a small vessel or you have removed it partially and it bleeds in the postoperative period, you blame it on normal pressure perfusion breakthrough. The thing is to identify small vessels. As I mentioned during my presentation, that post-operative, after you have removed the AVM, the whole thing should be completely white. Means there should be no redness. It should be complete hemostasis. And if you have complete hemostasis, it means you have taken all the small vessels. If there is a small bleeding, and if you have put, if you have put, you know, Surgicel and gel foam and all those things, it will bleed, and then you blame normal pressure perfusion. As you have seen in my presentation, I have shown you such huge AVMs, such high flow AVMs. I don't believe personally in the concept of normal pressure perfusion breakthrough. So that is my answer.
Okay. Can you see the questions on the panel there?
Yeah.
Yeah, you can pick one you want.
See, the question is from Rania about aneurysms inside the nidus. See, aneurysm inside the nidus can be, they are part of the AVM, and that you have to remove. The whole thing will come with the aneurysm venous nidus or part of the AVM nidus. Now the question is holding of the instruments in left hand and right hand. See, the most important thing that I do in the surgery is I change my hands. If you see on several occasions, the suction will be in the left hand. In bleeding situations, in particular, my suction will be in the right hand. So when I use the suction in a bleeding situation, I use suction in the right hand because it is a dominant hand and you can suck with little bit pressure, and then you dissect and expose the rest of the thing with the left hand. So more importantly, I think that we should be having, you know, the use of both the hands. So more importantly, I use right hand in majority of my cases with a bleeding situation. Another question that here is, how often do you need to take up DSA in addition to CT angio? I think I like to do DSA in all my cases, because DSA, you can go and see the DSA being done and you can see the flow of the AVM. And I don't think I will like to compromise on any kind of investigation before I touch the AVM. I want to have very big information, no compromises. You see, I work in a hospital where compromises are possible, like, oh, it is expensive, don't do it. Oh, MRI is expensive, don't do it. Oh, CT angio is expensive, don't do it. I work in that situation, but my concept has always remained that if you have to do big operations, you have to do all investigations. You just cannot compromise on investigations. So that is my answer to this question. Role of perineidal capillary vessels and post-surgical angiography. See, post-surgery, you have, if you remove the AVM completely and beautifully, and as I mentioned to you, if you know the small vessels, if you really know the small vessel, which is the trick of AVM surgery, and follow the small vessel bleeding, don't use any hemostat during the operation. The hemostasis should be complete without any hemostat. Then you don't have to worry about post-operative hemorrhage. If you leave small AVM behind, there will be post-operative hemorrhage. So partial resections is never a treatment for AVM. If you have to do, you have to do it completely. If you have to do, you have to do it absolutely completely. I think, John, these are the questions. I don't see any more.
Okay, I think Uday Baumek has a question. Do you have?
Yes, yes, I see.
Go ahead, Uday. Go ahead.
How do you tackle end passage vessel? You see, this is the basis of AVM surgery. This is the basis. If you take a normal vessel during operation, you create a huge disaster. Usually the vessels of AVM is a compact. Usually it is a compact nidus. And you can dissect like a meningioma. You can dissect like a glioma. Not in all cases, but in majority of cases. And you have to leave all these vessels which are passing along or side of the AVM. You cannot take these vessels. If you take these vessels, you damage them. You damage the person. So these vessels, this is the basis of AVM surgery. Now, another question that has been asked is, what is the cost of ordering 3D models? I must tell you that 3D model cost is not very huge. And we discussed this model for the first time in the literature on 3D models of AVM and for craniovertebral junction, as I showed you the other day. 3D models are not very expensive. I will say in India, for me, I can get in about 600 or 700 US dollars, about 25 to 30,000 rupees.
Okay. Okay, Dr. Atul, what's the topic for tomorrow?
I will think about it, John, today, and I will let you know very soon. Maybe I'll talk on cavernous sinus surgery tomorrow.
Okay, you'll let me know. And thank you very much. And thanks all the panelists for coming. And we'll see you tomorrow.
Thank you very much, John, for this
Okay.
wonderful opportunity.
Great. Okay, we'll see you tomorrow.
Bye-bye. Bye-bye.
Bye-bye, everybody. Thank you for coming.
Thank you.